Good morning, everybody. I'm Professor Chris Nestor from the School of Health and Society at the University of Salford in the UK, and it's my pleasure to be speaking to you about foot orthotic practice. Only sorry, of course, that we can't meet face to face in beautiful Paris and share some of your fine cuisine and fine wine. Perhaps on another occasion. I certainly hope so. I've been asked to speak about what comes next for podiatric biomechanics, and I'm going to make reference to some work we're doing in a European funded project. And the title of my presentation is actually the Value-Based Foot Orthoses Practice Model, or the Valuator Model. And this is a collaborative presentation with Kevin Deschamps, who's also speaking to you later on in the conference programme. As I said, this is a collaborative project. We're working with academics at Salford, Malaga in Turkey, and Kevin and Antoine over in Belgium. And we're funded by the Erasmus Plus project, which brings together universities to look at improving curriculum content. And specifically, we're focused on how it is that we teach undergraduate students about foot orthoses and the evidence base behind that. And if you'd like to know a little bit more about the project, I invite you to go to the Future Feet project website, which is futurefeet.eu. So what's the context for our project? I don't need to sell very strongly to this particular group the fact that there are increasing a number of people who are experiencing important and serious foot health problems and therefore need the services and care from foot health professionals, whether that's podiatrists or indeed other professionals. And that's because we have an aging population. We have higher expectations of what we can do when we are older. And we've got the epidemics in diabetes and obesity, which are compromising people's foot health. So there is an increasing unmet need for foot health care. One of the solutions to that is simply to produce more foot health professionals, more podiatrists, and certainly that is part of the solution. But amongst a range of other approaches to solving that problem, there are two in which this particular project is focused on. The first is to improve our uptake, our adoption of digital technologies. And we actually designed the project before the COVID pandemic. And in those times, the idea of digital and online consultations wasn't at all popular. But of course, over the last 18 months, we've had to change our practice very rapidly. And now this is quite common and routine for many practitioners. But it's a good example of how sometimes there are barriers to changing our practice. And actually, you need something significant to change, like the pandemic, to force the issue for everybody. And it's an example of how practice and services and professional skills can be advanced through the use of digital technologies. And by digital technologies, we don't just mean measuring patients, and we don't just mean online consultations. It can be about business marketing, it can be about business management and practice management. There's a range of ways by which the foot health workforce could improve its efficiency by adopting digital tools. The second area of importance to meet this unmet foot health need is that we make sure that our practice is aligned with the best available evidence, because that means we're going to be focusing on quality delivery and being efficient as possible. And it's that actually I'm going to talk about primarily in this presentation. So the Future Feet project is focusing on two things. One is improving the digital skills, digital literacy in the foot health professional community, and we're doing that through improvements in undergraduate and postgraduate education. And the second is about accelerating the transfer of knowledge from the evidence base, from research, into the curriculum at undergraduate level. And specifically, we're focusing around the evidence base around foot orthoses. And it's that second topic that I'm going to talk to you primarily about. The presentation is really a very light touch on one of the outputs that's already come from the project. So I want to invite you to go to the Journal of Foot and Ankle Research and identify this paper. It's an open access journal, so you can access this paper free of charge, and it's called the Biopsychosocial Digital Continuum of Foot Orthoses Practice and Research, or the Valuator Model. and it really gives it a much greater detail on the topics that I'll touch on in this presentation. Now, normally I would finish my presentations by giving you some take-home messages, but actually I'm going to give those messages to you now so that I can help orientate your thinking and how you listen to what follows in the presentation. So these are the three take-home messages that I want you to take with you in your professional work, even just next week. The evaluator model is an attempt to hold a contemporary lens, a more modern lens, over the evidence that we now have for a very broad range of factors which affect people's health and well-being, and therefore will affect the outcomes that patients experience from your practice. And in this case, we're talking about foot orthosis practice. And we say contemporary lens because it considers a full range of the evidence base around professional practice and assembles that evidence specifically around the area of foot orthoses. I think in contrast to previous models of orthotic practice, we want to stress that this is not a cookbook. This does not have all the answers dictated for you in your practice. The evaluator model is a framework for us as researchers and academics and students and teachers and practitioners and policymakers. It's a framework for us to have a conversation about professional podiatry practice and orthotic practice within that. And ideally, we hope it's a unifying language, because historically we have sometimes spoken different languages. Researchers investigate orthoses in their way, and practitioners understand and use orthoses in a different kind of way. And if those two worlds don't meet, then it creates a barrier for research being transferred into practice. And that's one of the things that we're trying to overcome with this model. The third take-home message is that this is about upskilling professionals, because it's empowering you to work with this framework and therefore to place evidence into your practice and your professional lives. And again, we think that's a really important strategic and philosophical step to take as podiatrists and in orthotic practice. So a little bit of introduction. I don't need to talk to you about what foot orthoses are. There are many national and international guidelines which provide recommendations for when orthoses should be used and what type of orthoses might be used as well. But I think we can all agree that there are some unresolved issues with orthotic practice. One of them is that we don't have a very clear and very well evidenced understanding of the mechanisms by which they have their effect. We know that orthoses can change pressure under people's feet, and kinematics seem to change too, and Ian's already talked to you about the evidence base for how kinetics and forces change around foot joints. But ultimately, we don't necessarily know how that links to any pathological tissue inflammatory process, any of the biomarkers that we might associate with, for example, changes in pain. So we don't have a full explanation of the mechanism of effect of orthoses and why it is that that effect varies between different people. One of the challenges with that is that different patients and different clinicians have different clinical endpoints. And so if you're interested in pain, and again, Ian's already talked to you about this, understanding how it is that you might change your orthotic design to influence someone's pain is really quite complicated, because pain itself is a very complicated concept. Another person might be interested in reducing their pain, but understand they can't eradicate it. So they're more focused on changes in their physical activity or their participation in sport and exercise. So we have a range of different endpoints for different people in different parts of our practice. And for me, the third element of these unresolved issues is that we've got rather stuck, and the conversations have got rather stale. And for me, we're going round in circles, and we have been for the last decade or more in terms of orthoses research and the evidence base behind orthoses. We're still largely talking about issues around capturing foot shape, or whether prefabricated or custom orthoses are better than each other, or in what circumstances. And I think what the evaluator model tries to do is to break us out of that fairly unhealthy cycle. Some of the issues behind that are twofold. The first is that we've retained a real focus on a biophysical approach to orthoses. We see them as devices that only have a biomechanical effect. And that's the context within which we use them and design them and describe to patients what their function, their role is. The second issue is that we haven't taken a very person-centered approach. Now, I would concede that that's probably unfair for experienced practitioners who actually often do take a very person-centered approach. But what we teach our undergraduates is exclusively a biomechanical model of orthotic practice. We're exclusively focused on the biophysical nature of the complaints that our patients present to us and the biophysical impact that orthoses can have. And the evaluator model is a way of expanding that thinking as we're teaching undergraduate students, so that as they enter and progress through their professional lives, they have a much broader and actually evidence-based understanding of orthotic practice. And just to expand on some of that a little bit, the current concepts around orthotic practice are really anchored, really stuck on this dose-response model. The idea being that if I change the design of my orthotic by shape or material, then I change the force inputs to the foot, and therefore I will get a very predictable change in the outcomes I want for patients. If I change the shape, I change the pressure, I change the kinematics, and the pain goes away. And there's a very explicit relationship between these inputs and these outputs. But actually the evidence base behind that is pretty thin, pretty patchy. And one of the reasons for that is that we have been ignoring the evidence base that's now very strong for the influence of non-biological factors in people's experience of health and well-being. And again, as Ian has already touched on, how it is that, for example, that pain is a very complicated issue. And the idea that we simply have a clear relationship between input design features in orthotics and output in patient experiences simply can't be true. It ignores a great deal of evidence now. So on the right-hand side of this slide, it begins to illustrate that there are psychological factors, there are social factors which influence people's health and well-being that we need to incorporate into our thinking around our professional practices and into our orthotic practice. And we've tried to capture and structure those psychological and social factors within the evaluator model. Now, the diagram on the left is quite complicated. I'm not going to go through that in detail in this presentation. I invite you to go to the paper in the Journal of Foot and Ankle Research for more detail on that. But the principles that we're talking about are captured really nicely in this diagram at the bottom. And this plots on the vertical axis biological factors, on the left axis psychological factors, and on the right-hand axis social factors which influence a person's experience of health and well-being. And no one's expecting us to plot particular patients along these three axes, but the concept here is that we all experience biological, psychological and social factors that affect our health and well-being. And this black line here represents the trajectory for a particular patient. And at different time points, there are a different combination of biological, psychological and social factors interacting for a particular patient. And what this allows us to understand is that if we are to improve someone's health and well-being with a device like a foot orthotic, we need to understand how the factors on these three axes are interacting for a particular patient and use our orthotic practice and our clinical encounter with that patient to interact ourselves with these three factors. Whereas at the moment, we're only really talking about orthoses along the biophysical, the biological axis. The aim of our practice then is to recognize that sometimes this black line for patients goes outside this middle zone. The middle yellow zone here is what we call the zone of optimal stress, and it means that the biological, psychological and social factors are somehow interacting in a way that's balanced and enables that person to live out their health and their well-being as they would like. But there are occasions when some of the factors along these axes take the patient outside of this optimal stress zone, or because of disease processes, that zone gets very narrow and they find themselves outside that optimal stress zone. And therefore our professional practice is about putting that patient back into that zone. And that requires a very personal and person-centered approach to understanding what it is that's happening for these patients, and what the barriers and facilitators to improving their health and well-being might be. Importantly, I want to stress that if we in practice can talk about biological, psychological and social factors, then we in research can talk about these three factors, and we can teach these to our students. And suddenly different parts of the foot health community are talking the same language, whereas at the moment we're not talking the same language. And that means that the transfer of research evidence will be accelerated into practice because we're all talking the same language. So the valuator model is based on 6 key areas. The first is a very broad approach to value, and what that means is that there are a range of stakeholders involved in providing health and social care and changing people's health and well-being. There's the patient, their family, there's the professional, there's policymakers and people who pay for health services. And that actually all of those stakeholders need their values recognised and respected. The second area is that we have a person-centred approach to goal setting. We're really trying to understand what it is we're trying to achieve for that individual patient and all those biological, psychological and social factors which might impact on that goal, achieving that goal. We recognise this zone of optimal stress and that people might find themselves outside that zone or having a very narrowed zone because of some disease process, and that our role as a professional is to help them to get back into that optimal stress zone. We obviously need something practical to do with patients in clinic in terms of assessing their biological, social and psychological factors, so there's an assessment to undertake with them. We have a commitment to monitoring value, which means how do we monitor whether we're making progress towards the stated goal? What are the important markers that progress is happening as we would expect or not? And how might we respond to that information about the progress we're making? And the final area, number 6, is about the clinical strategies that we might have to support our very person-centered engagement with the patient, and ultimately what some of that means for our foot orthotic design process. Now all of this is fairly theoretical, so I thought we'd bring it to life with a case study that Kevin has from his own practice. So this is a 55-year-old mechanical engineer. He's been experiencing pain in his left foot for 9 weeks, but actually he's been experiencing some discomfort in both his feet for 9 months. The pain is around the medial malleolus and the medial arch, and there is no underlying chronic health condition other than he has some hypertension. He's been attempting some conservative treatment with non-steroidal anti-inflammatories for a couple of weeks and some physical therapy. But what he's coming and reporting is actually that he's experiencing some increased work-related stress because he's actually had 2 weeks off work in the last 2 months. And that is of concern to him, and he's feeling less productive and experiencing less comfort at work. And actually this is really what brings him into the clinic. He's having a personal experience around his absenteeism at work. The pain's been there for quite some while, but actually for 9 weeks, but actually what's bringing him in is the fact that he's now off work. And I think we've all experienced over the last 18 months what a change in our work routines can mean, what being away from the physical environment of work, the social environment of work can mean for us. And it's frequently a very negative effect. On physical examination, there was pain over the left tibialis posterior tendon. The pain was scored as 7 on 10 at its worst, so quite significant. On standing, there was some heel valgus and some abduction of the forefoot, so you're getting an impression of the sorts of structural arrangements of the foot. But there was no signs of any muscle weakness when it was manually tested against manual resistance. On weight bearing, however, there was some poor muscle selectivity and force generation, and some suboptimal control in the frontal plane of pelvis, knee and hip and ankle. And so there was some movement control happening, some movement control issues for this particular patient. Now I must stress this is not about saying that that's the cause of his foot pain. What we're doing here is we're describing that this is part of that patient's context. It could be that movement difficulty is a compensation for the pain that he has, or related to the pain, we don't know. what we're saying is it's in the field for this particular patient. We need to be aware of it. And the patient's BMI was 28.5, and he was reporting that he had put some weight on due to reduced physical activity because of the foot pain, and he'd begun to get frustrated with that. Now, this is where I think the valuator model comes a little bit more into its own, because all of what I've just described is fairly routine clinical practice. But as part of taking a more patient-centered and broader approach to understanding psychological and social factors which impact on health and well-being, as part of the evaluator model, you would also undertake something like this, a patient health questionnaire. And this one in particular focuses on the potential impact or potential evidence for low-level depression in patients. I want you to focus on the top 6 or 7 questions here. And this asks this particular patient to rate, over the last 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things. And he said several days in the last 2 weeks. Feeling down, depressed or hopeless, several days in the last 2 weeks. Trouble falling asleep or staying asleep, that's not been a problem. Feeling tired and having little energy, several days over the last 2 weeks. Feeling bad about myself, or that you're a failure, or you've let yourself or your family down, several days. Trouble concentrating on things, such as reading the newspaper or watching television, several days in the last 2 weeks. This is a standardized score with standardized measurement scales and rating scales. And what this reveals for this patient is there's some evidence of low levels of depression. And so that could influence, for example, how that person is experiencing pain, their approach to some of the advice that you might be giving them, their approach to their expectations about whether they're going to get better or not. And all of that could influence your thinking around how you will deal and advise with this particular patient. In a similar way, the Tampa scale for kinesiophobia was used on this patient. And again, I want to focus your attention on a subset of the questions. I'm afraid that I might injure myself if I exercise. This patient strongly agrees with that statement. If I were to try to overcome my pain would increase. He agrees. My body's telling me I have something dangerously wrong. He agrees with that. My pain would probably be relieved if I were to exercise. He disagrees with that. And people aren't taking my medical condition seriously enough. No, he disagrees with that. He has been taken seriously enough. But there's this range of responses here, plus some others. And again, using this standardized scale, actually this patient has a considerable fear of movement. And coupled with his low levels of depression and the pain and his reported increased weight and his frustration at not being at work, this begins to build a picture for you around some of the psychological and social factors which are interacting for this patient and need to form part of your understanding of how you might approach this individual. So Kevin and colleagues completed the physical examination, the psychosocial evaluation we just discussed. There was also some medical imaging and gait analysis, and brought this patient in to develop a person-centered approach, bringing all these things together. And part of that was trying to identify what are those clinically meaningful endpoints for this individual patient. And we're going to focus on 3. So reducing pain and discomfort in daily activities, increased work-related stress due to foot pain, that we want to reduce that, and the kinesiophobia. I want to say that just evidencing for the patient that they have a fear of movement, showing empathy that you understand their experience, providing them with an explanation as to why they're worrying about movement in the way they are. They may not have fully recognized and understood that for themselves. Demonstrating that empathy, doing that listening, is providing a very powerful trust between you and the patient. That will have a direct impact on that patient's expectations, a direct impact on their attitude to listening back to advice, and, for example, their compliance with footwear advice or orthotic advice. These are really important opportunities that have been highlighted to you as a professional by undertaking that psychological and social factors assessment, the kinesiophobia and the depression scale. It also allows you to potentially raise the question of how that person is experiencing their own moods and point them and refer them on for greater support. You will also have your clinical endpoints, and just highlight this one here. You as a professional might want to recognize the fact that you don't want this to progress to stage 2 posterior tibialis dysfunction. And so you might use ultrasound, and that's what Kevin did, to check on the condition of the tendon and begin to check for the risk of progression and biomarkers for progression. So the patient has their endpoints, and you as the professional might have your own. We're using this as a case study because it illustrates the value of taking that broader perspective on the factors which affect people's health and well-being, and therefore affect the relationship between what you choose to do as a professional and the outcomes that patients will experience. And for us in contemporary practice, the selection of particular foot orthoses or their features, their materials, the colours, the shapes, is guided by a range of things now. It's things like the fear of movement, it's the patient expectations, and it's all the usual things like foot shape and plantar pressure changes that you're trying to achieve. But the point is to have a much more honest, transparent and evidence-based approach to the conversations around foot orthoses with your patients, the conversations you're having around their health and their well-being, and the role that you and your orthoses can have in changing that positively for individual patients. So again, a reminder of those take-home messages. This is about providing a different kind of lens that connects the evidence base for factors which influence people's health and well-being with your practice, so that you can align what you do with patients with the best available evidence. And in this case, we're focusing on foot orthoses. It doesn't provide you with all the answers. Actually, we think it really empowers you as professionals to have a clear framework for that intellectual discussion and debate about how it is those psychological and social and biological factors interact for individual patients. And that's a much more mature conversation for us, I think, as a profession. And that this is about upskilling professionals and yourselves in what is the available evidence and how it can be applied in your individual practices. I'd like to say thank you very much for your time and for listening this morning. I invite you to go to the Future Feet website, and hopefully I've left just enough time for a few questions at the end. But if there's not time, please feel free to email myself and Kevin, and we'll be very happy to hear from you. Thank you.